Dear Chair, dear audience, my name is Adolf Lichtfusz, and my PhD thesis title is Imaging and Intervention Strategies in Invasive Cardiac Procedures. I'm a resident and cardiac surgery department at the Central Hospital of Northern Pest, and my vision is to achieve optimal outcomes for patients through precise assessment and tailored strategies in invasive cardiac procedures. And my mission is to identify individualized treatment approaches by integrating advanced imaging and evidence-based techniques for patients with complex cardiac conditions. I have two ongoing projects, both of them are meta-analysis, and my first project is Transcatheter edge-to-edge repair does not improve left ventricular reverse remodeling in secondary mitral regurgitation. Heart failure affects more than 64 million people worldwide, and mitral regurgitation is the most common valvular heart disease in heart failure patients, affecting almost 65% of patients with chronic heart failure and 50% of those with acute heart failure. Transcatheter mitral valve repair, or TMVR, is a possible therapeutic option for patients with severe mitral regurgitation with high risk for surgical valve repair. While TMVR has been shown to improve symptoms, it's uncertain if it's by reversing left ventricular remodeling. So our aim is to evaluate to what degree the TMVR procedure slows heart failure progression by measuring its effectiveness on reversing left ventricular remodeling. Our first clinical question is the following. How transcatheter mitral valve repair influence heart failure progression? Our population is heart failure patients with mitral regurgitation, and we would like to compare the baseline data and the follow-up data of the patients who got TMVR plus guideline-derived medical therapy. And our primary outcomes are change in echocardiographic parameters, and our secondary outcomes are change in NT-proBNP and mitral regurgitation. And we hypothesized that transcatheter mitral valve repair causes left ventricular remodeling. We have a second clinical question, which is transcatheter mitral valve repair more effective than pharmacological therapy in slowing heart failure progression? In this part, we would like to compare TMVR plus guideline-derived medical therapy to guideline-derived medical therapy alone in left ventricular reverse remodeling. And here we hypothesize that transcatheter mitral valve repair has a superiority in effectiveness on left ventricular remodeling compared to guideline-derived medical therapy. We conducted our search in three main online databases. We started with more than 9,000 articles, and we are gathering data from 38 articles. Down here you can see our search key. The first domain contains information about mitral regurgitation, and the second domain about the TMVR technique. Before I show you my results, I would like to say a few words about reverse remodeling. So basically, in heart failure, the heart muscle architecture changes and the chambers dilatate. With adequate treatment, we can reverse this process and shrink the chambers. The guidelines say that 10% shrinking or change back to the original size is a clinically relevant reverse remodeling achieved by a treatment. So first, I would like to show you the technical success of the procedure. Here you can see that before the procedure, the grade 3 and 4 mitral regurgitations were present in the 99% of the patients, and after the procedure, it was presented only in 9% of the patients. So we can call this, this technique technically successful. One of our parameters are left atrial volume. Here you can see that the between study heterogeneity was high, and our effect measure was mean difference. You can see that The intervention achieved a minus 5.70 change in left atrial volume, but it was not clinically relevant nor statistically significant. Another parameter is NT-proBNP. Here you can see that the heterogeneity was moderate, and we had a pretty good reduce in NT-proBNP. It was clinically relevant and statistically significant. For the other parameters, you can see that although we had statistically significant results, only one was clinically relevant. And in the comparison on the TMVR to the guideline-derived medical therapy, we didn't have nor statistically nor clinically relevant changes after the procedure. Our study has strengths and limitations. As strengths, we can say high patient number, many different follow-up periods, and a unique study design. But as a limitation, we can list that we only had 2 RCTs and a few studies with long-term follow-up. As a conclusion, we can say that although TMVR procedure was technically successful, there was no clinically relevant change in the main echocardiographic parameters, nor any significant differences in cardiac reverse remodeling favoring TMVR. As an implication for practice, benefits of TMVR in cardiac reverse remodeling may be limited, so clinicians should make this, take this as consideration when choosing this therapy. And the implication for research, we should identify which patients benefit more from TMVR and explore other factors influencing its effectiveness. And high-quality randomized controlled trials are also needed. Our study is under review at the 3rd journal at JACC Heart Failure at the moment. And my second study is epiaortic ultrasound in cardiac surgery, reducing perioperative stroke risk through improved aortic assessment. It's also a systematic review and meta-analysis. So stroke in cardiac surgery affecting up to 5% of patients significantly increases mortality and healthcare costs. Atheromatosus plex in the ascending aorta is a major risk factor for perioperative stroke due embolization during aortic manipulation and cross-clamping. Often underdetected by standard intraoperative methods like digital palpation and TEE. Epiaortic ultrasound is an intraoperative method which provides direct visualization of the aortic valve and atheromatosus plex. Using this technique, and when we saw atheromatosus plex, we can adapt our operating strategies like altering clamping sites, minimizing aortic manipulation. So our aim is to evaluate the effectiveness of epiaortic ultrasound in reducing perioperative stroke in patients undergoing cardiac surgery. So our clinical question is the following. Does the use of epiaortic ultrasound in patients undergoing cardiac surgery reduce stroke rate? Our population is patients undergoing cardiac surgery involving aortic manipulation, and we would like to compare epiaortic ultrasound to standard assessment methods. And our primary outcomes are stroke rate and perioperative mortality. And we hypothesize that epiaortic ultrasound reduces stroke rate and mortality in cardiac surgical patients. And as a clinical implication, we can say that surgeons can use an alternative operate strategy based on the findings of this epiaortic ultrasound. We conducted our search in the three main online databases. We started with more than 11,000 articles, and we left off with 14. we finished our full text section, and we are now extracting data from the articles. Thank you for your attention. Let me end my presentation with the words of Franklin D. Roosevelt: "A smooth sea never made a great sailor." Thank you so much.
Congratulations on your presentation. Regarding the epi-aortic ultrasound, if you were to perform it during the procedure, which step of the procedure would that be? I mean, after you open the chest, you perform the ultrasound, and then you decide how you proceed?
So after we open the pericardium, and we are planning to cannulate the aorta, we should check the aorta for plaques that we don't cannulate into a plaque, or we can choose our clamping site properly.
So it should be done on every patient, not select a specialist population?
Yeah, we have a risk factor for patients like obese patients or diabetic patients are at more risk, so we should check at them more often. But it can't hurt if we check every patient.
Congratulations to your presentation.
Thank you.
So regarding specificity and sensitivity, this intraoperative ultrasound examination. So what do you think about to compare the chest CT for just to discriminating high-risk patients compared to your non-invasive or minimal invasive ultrasound imaging intraoperatively? That was the first question. So, please.
Yeah, the problem is that we don't do CT scan in patients routinely before heart surgery, but we always have an ultrasound machine in the operating room. So it's more likely that surgeons would use this epi-aortic ultrasound than doing a CT scan before the operation. But of course, the specificity I think is higher with the epi-aortic ultrasound because you can check right at the cannulation sites this aortic plaques.
Okay, thank you. And the second question is for the TMVR and the mitral regurgitation patients. What do you think about to find a subgroup of patients who might have benefit from the TMVR procedure compared to the guideline-directed medical therapy? So,
I think the TMVR technique is the most effective at patients who have symptoms, aggravated symptoms like dyspnea. And I think if we would like to achieve a long-time effect, it's enough to give guideline-derived medical therapy, but with TMVR, we can improve the quality of life in patients.
Is there any subgroup of patients who maybe or presumably might have benefit from this procedure?
Yeah, I think patients with baseline ejection fraction and a higher grade of mitral regurg would benefit more from the TMVR.
I have also two questions. One is probably a misunderstanding. Can you go back to your first slide?
Yes, of course.
You mentioned the number of patients suffering from heart failure worldwide. It's only 64 million people?
Yeah, based on the data.
Okay.
I think it's only the diagnosed patients.
Okay.
Of course, it's more
because given the rate on cardiac failure, death, it's probably. I would have estimated it much higher. And I have a second question regarding your ultrasound thing. Stroke is an issue in this type of patients, but we do know that most strokes do not occur from atheromatous plaques. The major issue is bubbles of a bad heart lung machine. So would it be manageable to see those bubbles in the ultrasound as well? Or it's not a continuous ultrasound, as I understood.
Yeah. While bubbles are a risk factor for stroke and even cardiac ischemia after surgery, we have filters in the heart-lung machine for the bubbles, and after the declamping of the aorta, we are doing the deoxygenation of the heart chambers and of the aorta. So in this case, when we are manipulating on the aorta, like cross-clamping it or cannulating into an atherosclerosis plaque, it's a higher risk for stroke than bubbles, because we are doing safety measures for bubbles, but we can't always do a safety measure for the atherosclerosis plaques.
Okay, so congratulations for you as well for the nice presentation. And a small question is that you mentioned that there are results when there is statistical significance but no clinical significance.
Yes.
And my simple question is, how do you know if you check a forest plot that it is significant or not? And how you determine what is not clinically relevant? So please share the audience with these details.
As a statistical significance, we can see that in the confidence interval there is a positive value of 4, and we should have both of the values in the confidence interval should be minus. So don't attach the 0 point.
Good answer, thank you.
Yeah, and in the clinically relevant part, I could say that I mentioned before that 10% change of the heart chamber shrinking we call clinically relevant. But in these cases, we didn't achieve a 10% shrinking of the heart chambers during the follow-up period.
And how do you know this is that 10% is the clinically relevant threshold? So how much evidence do you have behind this statement?
Not enough, I think. But now it's the studies say that this is the clinically relevant threshold.
Mm-hmm. Okay. Well, thank you very much.
Thank you. Thank you.